great. Thank you very much for joining us today. My name is Kyle Wilby. I'm an associate professor here in Halifax at the College of Pharmacy and the Faculty of Health at Dalhousie University. And I'm excited to be here presenting with Sam. Sam, do you want to give a quick introduction?
Yeah, my name is Sam. I am a pharmacy student at Dalhousie University. I just finished my third year, so I've been working in 2SLGBTQ plus health with Kyle for about a year and a half. So I'm really excited about presenting this information to you all.
So we're here to present Practicing with Pride, top 10 actionable strategies to improve 2SLGBTQIA plus health in pharmacy. And this work is really interesting for us because it's based on a research program that we've been doing now for the last couple of years. And we're really excited to share those results with you today and to hopefully translate that research really into those practical strategies that pharmacists can do and pharmacy team members, whether you're a technician, a pharmacist, or any member of the team once you enter practice and start to work with patients in this space. So we do have some disclosures here. I'll give Sam's disclosures for him, but he doesn't have any relationships with any commercial interests. For myself, I do have an unrestricted research grant from Shoppers Drug Mart, and we both have received a speaker's fee from CPHA for this learning activity. Our learning objectives are here. By the end of this session, we hope that you'll be able to describe health disparities that exist within the 2SLGBTQIA+ population, outline how stigma and discrimination can lead to avoidance of care, and list at least 5 actionable strategies to improve care for 2SLGBTQIA+ people in pharmacy practice. And just as we move forward, I wanted to clarify that sometimes we use different forms of the acronym. So the form that's on your screen there is typically the most common one we see these days. However, we might default to saying things like 2SLGBTQ or LGBTQ, and that's fine. It's just a way that we're going to reference the population as we move through. We also like to start our presentations by giving you an idea of who we are, because it's really important to understand the lens that we bring to this work. We are talking about the 2SLGBTQIA+ population, but we're also only one component of that population. And so although we have lived experiences and research experience, we'd just like to give you an idea of who we are. So that's me there with my cat named Ash, and if you follow me on social media, he's pretty famous. But I identify as a white, cisgendered male, which basically just means that I was assigned male at birth, and that's what I now identify as in terms of my gender identity. I do identify as gay and without disability. And I have lived in different countries, which makes my experience a bit unique because I've lived in countries where there are laws against homosexuality. And so I have a bit of a different perspective there in terms of systemic discrimination and oppression, which we'll talk about as we move through. Sam, would you like to provide your insight here?
Yeah, so I am a gay cis white male as well, and I have no disabilities, and my pronouns are he and him.
Perfect. So where did we begin? It's really interesting working in this space because I might always talk about our research program, and that's not really rocket science because we simply are asking people about their impressions of pharmacy practice and community members' thoughts about how to make pharmacy more inclusive. But it's really interesting that just a few years ago, there wasn't really much in this space. It was a lot of conversations. It was a lot of things like commentaries where people were providing their opinions on how to make spaces more inclusive. And while that's all really good information, we decided to embark on a bit of a research journey and have listed or completed a number of projects in this space. And so Sam's going to talk to you a little bit about 2 of the projects, and I'll fill in the rest of the gaps here.
Yeah, so the first project that we decided to do was to see what the literature had to say regarding 2SLGBTQ+ people and their experiences within pharmacies. So we decided to conduct a scoping review initially that looked at articles from around the world. And we identified direct evidence that, yes, 2SLGBTQ+ people do experience stressors within pharmacies. And then we decided to categorize these stressors based on what's known as the minority stress model. And Kyle is going to be describing that a little bit more in the future slides. But then after that, we decided to look at our local population and to see how 2SLGBTQ+ people experience pharmacies within the Maritimes. So we did a qualitative study in which we interviewed 31 participants from the Maritimes to see how they experience pharmacies. And from that data, we identified that they also experience stressors here. And also they typically avoid pharmacies because of this. And also based on the study, we identified strategies that pharmacies or pharmacists can utilize to help make their environments more inclusive and affirmative for this population.
And it was really great kind of moving the conversations forward from, the literature review into actually working with patients in Canada, because, the findings are quite surprising, and it's really informed a lot of the points that we're going to talk about today, and really just simple things we can do to make workspaces more inclusive. Just to give you a sense of where else we're headed with our research program. So we're currently, we have a manuscript in review about coping and how patients or 2SLGBTQ+ community members change their behaviors in pharmacies. We also looked at hospital pharmacist needs. So surveyed our national hospital pharmacy workforce. We're putting some results together there in terms of what we can do to better our resources available for that sector of practice. And then we have an ongoing study looking at what do identifiers say. So identifiers as part of the 2SLGBTQ+ community and part of the pharmacy workforce, and what insights can they give us to help make our workspaces more inclusive. I'm going to just go on a couple slides here about some of the heavy stuff, so the health disparities, because sometimes when I speak in this space, people think, why do we need to talk about this? Why is this a problem? And so, as you can see here from these statistics, the data isn't great, but we're getting more data that's coming out every year. And we have a greater prevalence of physical and mental health disparities within the population. So quite interestingly, there's a greater prevalence of arthritis and asthma in women who identify as part of this population. And sometimes people think, why would that be? Why are people having these physical health disparities? And we'll talk about that in the next couple slides. Another really kind of shocking example is that anal cancer rates are up to 30 times greater for cis men who have sex with cis men. And while that can be a little bit surprising, I think, and one hypothesis is that it comes down to the fact that we've missed a whole generation, including my generation, for HPV vaccination. And even though now in many provinces that HPV vaccination is funded for gay and bisexual men who have sex with men up until they're 45, the community doesn't really know about it. So it's another example of systemic oppression where we're not advertising and promoting these services, which could actually be available and help to reduce this disparity that we see. And then, of course, we have increased risk of HIV and other sexually transmitted and bloodborne infections, as well as mental health disparities. In terms of mental health outcomes, we are getting new data. I think this year it's coming out shortly in this space, but from this data here that we can show you, lesbian, gay, and bisexual people rate their mental health more commonly as fair or poor. So the higher the bars there, the less, or the more commonly they'd be ranking their mental health as poor or fair as compared to the heterosexual population. And that's something that we commonly see. And when we translate that into actual outcomes, we see increased depression and anxiety, increased suicidal ideation, 3.5 to 4 times higher, and that's specifically for sexually diverse people. But when we look at trans people in particular from other statistics, we know that statistic sharply increases, which is really troubling. And increased substance use, so people coping in a negative way. And why we need to have these conversations here with pharmacy and with healthcare is because healthcare professionals and healthcare settings really do come across as the top sources of perceived stigma when we're looking at kind of stress in general for this population. I usually give a really complicated figure at this point in my presentations and talk about the minority stress model, but I've simplified it down for you here today, just to give you a sense of why we're talking about avoidance behaviors, why we're talking about inclusive care. And so what this diagram really shows is that stigma and discrimination that exists in society or exists in healthcare can result in healthcare avoidance. But why it is even maybe greater for this population is because it triggers these internalized stress processes, which might make people even further want to delay or avoid care. Stigma and discrimination could be something like a past experience where someone felt judged by a pharmacy technician or a pharmacist or a doctor or a nurse, whatever healthcare context it was maybe asked invasive questions that they didn't want to answer. Or it could be things like laws and regulations in a country or prescribing protocols, which we'll talk about, that might actually be discriminatory towards the population. When people encounter those processes, it triggers these internalized stress processes. And the most common ones we see for those are expectation of rejection. So if I had a negative experience in one pharmacy, I might now transfer that to other pharmacies. And the need for concealment, where I always say I've lied to healthcare professionals for the majority of my life. And by telling people that I was straight, as an example, then maybe I wouldn't get offered that HPV vaccine, or maybe I wouldn't be offered PrEP or things that could actually be really helpful to me in terms of my sexuality. And those stress processes all come together and result in this healthcare avoidance where people delay or avoid care. So if you remember those statistics where we had greater prevalence of asthma and arthritis in women as part of the community, it's likely not because of anything physical that's different, but because people might present at a more severe state of their disease, or people might let things go a little bit longer and not seek treatment where we could actually cure or prevent progression earlier. So that's why we're seeing the mental health disparities, but also those physical disparities are also starting to pop up.
Yeah, so to add to the minority stress model, there are also coping strategies that we identified from our interviews with community members. And here is 5 of them that we identified, where avoidance and concealment is very similar to what Kyle described earlier. But perseverance is essentially when someone kind of has to push through or mentally push through a negative situation, such as like if they were getting discriminated by a pharmacist or pharmacy staff. And they have to do that just to get the care that they need. So they have to endure that negative situation. Seeking support is when someone has to go out of their way to obtain competent care. So sometimes they might have to go to a pharmacy that's located much further than other pharmacies because that pharmacy has expertise in 2SLGBTQ+ health. So this could be like a barrier they have to overcome. And also seeking support could mean bringing somebody on with them, like as a support person, in order to help them through potential negative situations. And then lowering expectations is when, say, a patient has like no expectation of proper care from a pharmacist or just gave up thinking that they're going to obtain proper care. So that they just endure whatever happens, and whether it's positive or negative, they just don't have any expectations.
Yeah, so our goal with these, after identifying these coping strategies, is to hopefully use our actionable strategies that we're going to share with you today and make it so these don't need to happen, so that we can avoid people having to cope and just really receive that inclusive, affirmative, positive care that everybody deserves. And that's basically a lead into this slide. So what can we do to cut through those stress processes, cut through the minority stress that people experience, and hopefully reduce those avoidance behaviors? Well, that's where we're coming into our actionable strategies. And I think, Sam, you're going to start with the strategy?
Yes, I am. So the first strategy that we have here is with the use of intake forms within community pharmacies. So intake forms are less confronting than directly asking a patient for sensitive information. And it also provides patients with the power to disclose what they wish. So an intake form might include things like gender identity, pronouns, prefer name, and stuff like that. So through our research, we found out that a lot of people did value having this information disclosed to the pharmacy, but there was a subset of the population that did not want to disclose this to the pharmacy. So having it on intake form where it is an option is a really good solution for this. It also normalizes the collection of this data. So by using it more and more often in the pharmacy, it becomes part of the normal process, and it helps normalize it essentially. And then it can be used as an educational opportunity for others. So using an intake form lets patients and pharmacy staff see this information more often. And then people start asking questions, and the more questions that we can answer, the better, as opposed to just letting it go undiscussed.
And it's really interesting because in our research that we did with this study, I was really shocked about how much this was valued by patients. So it's interesting that like I think a simple intervention can be so powerful. And it really comes down to that point Sam said about less confronting than direct ask. People would much rather be able to write and choose to disclose what they want to disclose rather than, being asked verbally, what's your gender identity or what's your sexuality, when they might not understand why that's needed.
So another strategy that we identified would be to reduce cis or heteronormativity within pharmacies. So essentially what this is like protocols, guidelines, practices in pharmacies that are considered normal through the lens of heterosexual or cisgender people. But this might not reflect the values of other identities. So an example of this would be, we had a participant in one of our studies who went into the pharmacy looking for a prescription for isotretinoin. And currently, in order to obtain a prescription for isotretinoin, you require evidence of or proof of contraception. So this participant had to explain to the pharmacist that they were sexually active, but they couldn't get pregnant. And then after a lot of questioning from the pharmacist, she had to essentially come out as lesbian. And this can be quite distressing for certain people. So this is a really good example of heteronormative practices that we use in pharmacies. And another example of cis normativity would be through PrEP management in pharmacies. So in Nova Scotia and I think many other provinces, in order to obtain a prescription for PrEP, one must disclose that they are a man who is having sex with other men. And this may not be as inclusive for other identities who have, other people who have different identities, such as non-binary or transgender people. And this shows that certain protocols do not use the proper wording that would be inclusive for all identities.
And it really just comes down back to that point of, we're learning so much now about gender identity and sexuality, and really reviewing our protocols and procedures to make sure that we are inclusive. And I think what Sam said there in terms of the PrEP is a great example. I've just run a PrEP prescribing project in Nova Scotia. And according to the guidelines, it really does say gay, bisexual men who have sex with men. But what about our non-binary folks? Why aren't they represented in our protocols? Or, why did that lesbian patient need to be forced to come out to the pharmacist? Why couldn't we ask questions in a different way, such as, are you sexually active and at risk of getting pregnant, as an example? So lots of work there that we could do in terms of how we're asking those questions and how we're getting that information from patients. Some other considerations within this realm is sex-based calculations. So if you're calculating creatinine clearance as an example and using sex-based adjustments, how does that change when someone's been on hormone therapy as a transgender person or a non-binary person for over 6 months? And there's some really good guidelines, and we have some resources at the end that are going to, we'll be able to suggest to you in order to help you navigate that a little bit more. And to really understand that, we're looking at sex instead of gender when we're looking at those calculations for the most part. Another area which I think is rapidly evolving, and especially now as we look at many different TV shows and pop culture as well, we know that there's different types of relationships that are being normalized in society. So when I was in pharmacy school 15 to 20 years ago, we learned about erectile dysfunction and about how the man needs to, be with his wife for some time before the sexual activity occurs. Well, not every man has a wife, and one man might have multiple partners. We're living in an age where there's open relationships, there's polyamory, and these are normal types of relationships that are occurring in society. So we think that that's relevant for conditions such as ED, such as other types of sexual health care, as well as when we're considering partner and family support. I'm doing some work in the oncology space where your typical traditional support systems, which we might think about, could be very different if somebody is entering or within a different type of relationship that might not seem as traditional to us. So again, just trying to keep our minds open and understanding that there could be many different types of people and types of relationships out there to consider. Strategy number 3 is about education, but it's really about investing in education for all staff. And although this seems it could be targeted to managers and owners of pharmacies, it actually gets targeted to everybody, because if you're a frontline pharmacist doing some work or listening to this webinar, why not share it with all your staff? Why not share it with the front store workers? Why not share it with the pharmacy technicians and pharmacy assistants? Because everyone really plays that critical role when it comes to inclusive care. A patient's experience starts upon entering the pharmacy and ends upon leaving. And usually in that time period, they meet lots of people rather than just the pharmacists themselves. And I always say we can be the most culturally competent pharmacist, but if we're working within a system or a workplace where there might be other stigma or discrimination that exists, simply because maybe people don't know, maybe people haven't learned this yet, then it's not going to be as effective. So investing in education, pulling others into these conversations really might help to decrease those negative experiences. One of our key findings was that in pharmacies, it wasn't necessarily the interpersonal relationship with the pharmacist that bothered people. It was the looks and judgment they received from other employees or even other public that were in the pharmacy receiving services.
So another strategy that we identified was representation and symbols. So representation would be having different ethnicities or minority statuses within the pharmacy staff. And then symbols would be things like pride flags, pride pins, brochures, pamphlets, pronoun name tags, anything like that. So this allows for community members from the 2SLGBTQ+ community to look at it as a visual cue that your pharmacy is inclusive and welcoming for them. And through our research, we did find that this was something that a lot of community members did value and they did want within a pharmacy. But there was a specific subset of the population that looked at this as more of a performative or a method of financial gain. So it's important that if you do display pride symbols within the pharmacy, it must be done meaningfully and not performatively. And then also it's important to ensure that all staff have received orientation/training on inclusivity. So if an identifier does come to the pharmacy, all staff can direct them to the care that they need or aid them based on their identity.
Yeah, it all comes back to that whole, we display these symbols and, what does that actually mean? Everyone I think really wants to be supportive, and it's Pride Month, it's June month right now. But when those symbols are displayed for people in the community, we really see that as a safe place. So as Sam said, we need to make sure we're doing that meaningfully. That doesn't mean you shouldn't display those symbols, but having these conversations with staff, investing in education for staff, and understanding, hey, if someone came in, with a question that you can't answer, where could you send them in terms of a community resource, or maybe you look up a resource, and again, we've got some information coming at the end of the presentation. We are actually furthering our research in this area in particular, so stay tuned for that, because we'd like to understand, what is the community's expectations when we do display these symbols in pharmacies, and how can we, better educate the pharmacy workforce in order to, make sure that we're doing this in a more meaningful way. Strategy number 5 is, again, kind of education-based, but it's about learning. And I think the most common thing I hear in this space is, hey, I'm getting these prescriptions, I'm getting these things come in, but I just don't know what to do, or I don't know where to go, or I have never learned this before. And that's fine, because we, including me, all went through, school or training where we weren't having this as content in our curriculum. It's very new. In terms of incorporating gender-affirming care and specific aspects of 2SLGBTQ+ health into pharmacy and pharmacy technician curricula. But now it's up to us to learn. So yes, there's some, there are some CPD things out there, but I wanted to kind of summarize the more general topics or more popular questions that I get asked when I do teaching in this space. So some things to focus on in order to be prepared for those patients that come to your pharmacy is really about hormone therapy, is probably the big one that I think most people feel relatively unconfident with, but it's really quite easy and straightforward once you learn and understand how hormone therapy works. So looking at estrogen and anti-androgens for feminizing hormone therapy, and then testosterone for masculinizing hormone therapy. Again, we've got resources coming to help you out with that as well. And it's important, I think, to not just think about the therapeutics with respect to how it works in terms of onset of action and expected effects over time, and of course, adverse effects and all of those things that we think about as pharmacists. But also what came out from our interviews was administration techniques and administration supplies, including a patient that said they had to keep their the package of their needles that they use for testosterone injection because they weren't confident that the pharmacist that they would see each time at the pharmacy would be able to know which needles to actually provide to them for those injections. So again, we're putting this into our programs now, but for the workforce that's already out there, I think it's really important to understand this as a whole. And I think Sam alluded to this a little bit before, but we've got a pretty powerful quote there from someone from New Brunswick who said, I would take a bus for an hour each way to see a pharmacist who had some knowledge of gender affirming care. And rather than going just to the pharmacy beside their house. I think that's really powerful because it shows if someone has knowledge or takes interest or at least knows how to look up in terms of resources, that's really meaningful for the community and can not only help from a therapeutics perspective, but can also help to develop that trusting and collaborative relationship with the patient in order to bring them on board and help them access healthcare services. Those are the top 5 strategies. The next ones might be a little bit quicker, although I seem to talk a lot, so it might be a little bit more. But these ones are supposed to be more now of the ready to action for anyone that's working in in pharmacy spaces. So I'm going to turn it over to Sam for number 6 here.
So we did discuss pronouns a little bit earlier, but just kind of putting it out here because of the importance of pronouns. But a lot of people like it when you display your pronoun on a name tag, just because it of course, like normalizes the use of pronouns. And then, of course, using like intake forms, giving them the option to disclose their pronouns or not is also important for a lot of patients. And of course, using it in patient conversations, answering questions regarding pronouns and other things, it's important. But we did discuss this a little bit earlier, so this one's a little quicker.
Yeah, and I think it's important to note too. I think I always go back to something one of my trans, feminine, non-binary friends told me was, you know, in pharmacy, we sometimes don't really need to know much about gender identity. Like, it doesn't really impact care, but really that use of pronouns, if you're having conversations with patients, that could be is really impactful. So as Sam said here, I think it's good to, you know, have these at the forefront and make sure that we're using patients, you know, correct pronouns as they enter our spaces. Number 7 is to let go of assumptions. And this is really difficult because we all have assumptions. We're always going to have assumptions. We make assumptions every day, and that's just part of being human. But I think it's letting go or being aware of those assumptions that's really important. And these are really based on mistakes that I've made or things that I've learned along the way as I've developed more expertise in this topic. The first one is really that patients' goals of therapy for gender-affirming care may differ. I always thought, oh, if someone's on hormones, then they're going to want that maximum effect, right? They want that maximum masculinization, maximum feminization. But that's not necessarily the case. Some people might want some characteristics, but not all. So they might want lower doses or lower frequency of dosing. Others may want a more androgynous appearance. So again, it's working with the patient to understand what they desire in terms of the actual therapeutic effect. We also commonly talk about community stereotypes exist, and this one's a bit more difficult because it sometimes has validity, but sometimes doesn't. And I think really the point here that I want to make is, you know, being gay, and whenever I say that I'm gay or come out as gay to any healthcare professional, the first thing I always get, even if we're talking about something completely different, is, oh, when was your last HIV test? Or, you know, are you on PrEP, or are you HIV positive? And this even happened when I was married and in a monogamous relationship, and it was just kind of something where people are trained gay HIV and make that assumption that they need to, you know, clarify that status. Whereas, you know, in Canada, in many provinces, it's not just gay people that get HIV. There's, you know, HIV affects many different parts of the community. The other one that we commonly see is trans and mental health. And yes, mental health is a core component and a core issue for trans people, but it shouldn't define them. You know, it should be something that we consider and work with people on, but it shouldn't always be the first thing that they hear about in terms of, you know, what are your, you know, what are your issues, how are you managing, and again, treating the patient as a whole and not just based on these conditions that we commonly associate with the population. The other learning point for me recently was that gender expression may differ from gender identity. So if you watch shows like Queer Eye, you'll see lots of pop culture references to this, but, you know, someone who was born male might express themselves more feminine, but could identify as a woman, they could identify as non-binary, they could still identify as a man, but just express their gender differently. So again, sometimes when we see gender expression, maybe that's opposite to what the patient's sex is, as an example, we make that assumption that they might have a different gender identity. But again, we shouldn't do that because it's up to that patient in terms of how they decide they want to identify, and could just be expressing their gender in the way that they feel and have the right to do so.
Yeah, so another strategy is discretion, and many 2SLGBTQ+ community members highlighted the importance of confidentiality and safe spaces to discuss their medications and to conduct other services that are not typically involving their medications.
And I think a really good example here, Sam, that comes up quite a bit in some of the work that I've done is just about having us realize that some patients might stigmatize certain medications. I think I always feel that I hate on doxycycline, but I take doxycycline regularly for rosacea. And in the community, doxy really has this stigma associated as being STI treatment for gonorrhea or chlamydia. And so if someone was, say, getting it for rosacea or getting it for acne, and you are counseling them on it, even though they know it's for that, they might have that stigma associated with it that it could also be used for these other indications. And they might really value that discretion of that counseling room because they might not want other people hearing about it because they focus so much on that stigma with that medication. And I think it really goes for, for anything, to be honest, in terms of discretion. But there are some medications out there where you just might not know how that patient feels about that medication. And even though we might not stigmatize it with STIs as an example, the community might. Number 9 is be an advocate, not just an ally. So we love allyship, we love our allies, and we need more and more of them. We want to challenge our allies to move into the advocate space, where we're actually creating change and seeing things happen, being at the forefront of system change. I talk a lot about system change, and it's a lot of that we've talked about today, and it's not that hard to do, and we need you in that space, no matter how you identify. More voices equal greater change. So sometimes I hear people say, oh, I'd love to fix the computer system, but it's beyond my control. Well, the more people that are calling up the person who makes that computer system and saying that we need that to change, the more power that's going to have. And that shouldn't be left to the identifiers. That should be us, the profession as a whole who's trying to advocate and make those changes. And advocacy is really everyone's place. We also get a lot of the time, oh, I just don't know, how to have those conversations because I don't want to overstep. I'm not an identifier. We need you in that space too. So being able to actually step up and speak on behalf of your patients, on behalf of your colleagues, that's what's going to be really important to create change. And although that could be easier said than done, was really happy to work with Caitlin, and I put the reference here for you, who's a pharmacist out in Alberta, used to be in British Columbia, on a paper that's open access through Canadian Pharmacist Journal, where we looked at advocacy as a professional responsibility, and we made some really distinct and clear recommendations on ways to do that when you don't identify as part of the population, and how you can actually influence advocacy and healthcare on an individual level, but also on a systems level. So again, lots to take a look at there, and really like to not move away, but help our allies continue to make strides and become advocates. And I think this is our final one, and it's probably, I think, wraps up everything all together, which is to see the person and not the identity. And I think labeling is very common in our space. Even yesterday, I forget the actual context, but I got called the gay professor again, which is fine. It doesn't necessarily bother me, but sometimes it's a bit, I'd like to be known as Kyle, or, not always the gay professor or the guy that does gay research or the gay associate dean. Which is really common to hear in our spaces. The same thing also holds true with people, or the trans community. Oh yeah, the trans patient. Well, maybe the patient's name is Michelle, right? And we could talk about Michelle and not refer to people always based on their sexuality or gender, which for some reason happens really commonly in our spaces. And you can see here, I was on the radio back last year, and although I was really thankful for CBC to have the opportunity, and I know that they didn't intend any harm by their headline, but you can see that, I was labeled as the gay pharmacy professor in the podcast that I did. And it can just have negative connotations for our community. We would never say things like that straight pharmacy professor as an example. So just to keep in mind to see the person and not the identity. And Sam, I'm not sure if you've had the same experience or not.
Not so much as a professor, because I'm not a professor, but I was called the gay best friend many times before. And I don't mind it, but for some other people, this might be like distressing, as other people might not see like their other traits or their hobbies or interests beyond the gay aspect. So I guess it's just important to not focus too hard on the gay title or the gay aspect of someone's identity and see them more holistically.
Yeah, and again, that translates whether you're gay, lesbian, bisexual, transgender, non-binary, however you identify in any way, and also, transcends over other populations too. And so I love the little line there that says sexual and gender identities are part of us, but do not define us. And so just kind of a nice point to close on as we wrap up these strategies. I promised resources, and here they are. So that I will put a caveat that there's not a ton out there at the moment, but there is some really good stuff. So first place I always recommend is local or provincial guidelines. Some provinces, specifically British Columbia and Ontario, have pretty good resources available. So health systems are places to go, the healthcare system. Sexual health centers may have different guidelines available. or maybe there are specialty clinics that could be ambulatory or part of acute care. We are going to suggest Sherborne Health and Rainbow Health Ontario. They have a really great set of guidelines there that the link is provided to you. And I really like these guidelines because they're really useful and easy to use, and talk about dosing, especially for hormone therapy, which is something that's really difficult to find, especially due to off-label use and all those types of things. There's some really great color-coded charts that are helpful for patient information, and some quick cards. So if I'm sure everyone is a busy clinician these days, but a really solid learning resource is available there. WPATH is the international guidelines really for gender affirming care. And while great and provide great insight, just keep in mind as you're accessing WPATH that they are international, so some things may or may not be relevant to the Canadian context. And then also Transcare BC, I really do like as well. I was trying to put together a presentation on gender affirming care and found specifics in here that I couldn't find elsewhere, including the Rainbow Health Guidelines, specifically around puberty blockers and other aspects of gender affirming care. So these are the ones that I go to most frequently, and hopefully will be helpful as you continue your journey learning about gender affirming care and inclusive care for 2S LGBTQ+ people. And with that, I think we'll wrap up here. So thank you very much for the opportunity to speak to you today. We want to leave you with 3 points: to be critical, reflective, and open to change, and to really help drive that change as allies and advocates. And it's been a pleasure to share our work with you. And if you have any questions, our contact information is there. Sam, any last words from yourself?
Just that I appreciate everybody taking their time to educate themselves within this field. Thank you so much, everybody.
Awesome, everyone. Happy Pride, and we look forward to hearing from you soon.